through some slides at the end. Um, my name is Ann Pedrick. I'm the Executive Director for the Child Death Review Commission, and we oversee FEMOR, which is Fetal Infant Mortality Review, but also what you've heard a lot about this morning, the Maternal Mortality Review Committee, which Lisa Klein chairs. She is the coordinator for that. Actually, she doesn't chair it. Dr. Cole Morgan and Dr. Vanita Jane chair it, but she's the coordinator. So she does a lot of the heavy lifting for that group. We also have Kim Petrella, who is the coordinator for the Delaware Perinatal Quality Collaborative with us. And her, along with Lisa and also April Lyons, who I do not believe will be with us because she was in the first session, she did a lot of the heavy work on many of the revisions. So we want to give a huge shout out to her. I'm going to go ahead and share my screen right now. And I will start it. And my apologies because I'm ill if I don't sound very clear. All right, so let me start from the beginning here. Okay, so I've already introduced ourselves. Like I said, this is a collaboration between the Maternal Mortality Review Committee, which is funded through the CDC through the Erase MMR grant, and also working collaboratively with the Perinatal Quality Collaborative and also the Delaware Healthy Mother Infant Consortium. For some reason, my slides are not advancing. There we go.
Come on,
Oh,
slides.
there we go. Now we go. All right. So these are our objectives for today to describe the status of MMR and also maternal mortality in Delaware. We're going to look at some of the national programs we evaluated and researched as we were preparing for this work, also our key goals, and also you're going to get to see the warning signs in multiple formats, and you're going to be able to conduct a survey for us, not right during this session, but later today or maybe tomorrow. In the next couple of days, we're going to leave it open for about a week, and we want your input. So I am going to share the next slide, which I believe is Lisa Klein.
Hi, how are you all? Thank you all for being with us today. So I want to talk to you a little bit about our maternal mortality review program in Delaware. And whenever we talk about maternal mortality review, we think it's really important that people understand what it is and what it isn't. And when we review cases of women who died during pregnancy or in the year after the end of the pregnancy, it is an anonymous and confidential process. The people who are on that committee have completed a confidentiality agreement, and they are required to not share the information that they have learned. When we share information for teaching purposes, we use an aggregated, a case study that might be several case studies that are rolled together. It is a systematic process, and we have very specific policies, state statutes, rules that guide in how we review these cases. And the goal is to move us from the data collection to prevention activities. But just as important is to know what maternal mortality review is not. It is not a mechanism to assign blame or responsibility for the death. We are not looking at individual providers. We are not looking at individual facilities. We are looking at individual cases and trying to find system ways that we might be able to prevent a death in the future. It isn't research. It isn't peer review. It doesn't replace an institutional review or root cause analysis or whatever else an institution needs to do, or existing maternal mortality M&M inquiries that facilities have. Next slide, please. So I want to tell you a little bit about our information from Delaware. And we are lucky in Delaware. We don't have a lot of deaths, but it's also related to the fact that we don't have as many births as a lot of states. So we might have anywhere between 8 and 12 maternal deaths a year, pregnancy-associated deaths a year. But because those numbers are so small, it's important that we protect the identity of the people who have passed away. And so we'll aggregate our data. So when we report our data, not only are we able to help protect the identities of the individuals, we're also able to get statistically a little bit better information on the deaths themselves. So for example, from 2017 to 2021, we reviewed 35 deaths. 1 in 4 cases were likely to be pregnancy related. And a pregnancy related death is a death that was causally linked to her pregnancy. If she had not been pregnant, she would not have died. And that is the question that we asked the committee when we're reviewing the case. If this woman had not been pregnant, would she have died? And what we find is that deaths that are pregnancy related may be related to a medical condition, but it may be related to a social condition, like she was homeless, or it might be related to substance use disorder or a mental health problem. So even those types of issues could make a death pregnancy related. 74% of the cases were pregnancy associated, but not directly related to the death, or we were unable to say that there was a relationship to the pregnancy. In Delaware, we continue to see significant racial disparities in both the number of deaths of Black birthing persons and whether or not it's a pregnancy-related death or a pregnancy-associated death. And the other thing that we're going to talk about is the fact that the overwhelming majority of our deaths are preventable, meaning that there are some kind of systemic actions that might have been able to be taken before this death occurred or during the final incident that might have prevented the outcome. Might have been something as simple as having Narcan available. Next slide, please. So this is just to give you a little bit of perspective, and we're using as our baseline the births in Delaware in 2019. So in the top set of bars is our births in 2019. And in Delaware, 28% of our births were to Black birthing women, Black birthing persons. And also in the very bottom set of in the very bottom bar, you'll also notice that 31% of the residents of Delaware, the birthing residents of Delaware, are African-American as well. Now look at the middle two bars. In our pregnancy-related deaths, again, if she had not been pregnant, she wouldn't have died. 78% of those deaths are to Black birthing persons. And of the pregnancy associated and not related or unable to determine, 38% are to Black birthing persons. So any way you look at it, we have more Black birthing persons than we have persons giving birth in the state, a much higher percentage. And this reflects what is being seen nationally. The rest of the country is seeing a similar situation where the deaths of Black birthing persons are proportionately exceeding the number of births that they have in that state. Next slide, please. So when are people dying? 22% of our pregnancy-related deaths are during pregnancy. Doesn't seem too surprising, but 23% are not related to pregnancy. So how can you be pregnant and it not be a pregnancy-related death? Maybe the person was in a car accident that was not at all related to the pregnancy. Maybe she had an overdose that, again, was not related to the pregnancy, or was in some kind of place that she shouldn't have been at the time, in a store when a holdup occurred, something like that. Unfortunately, we do see those kind of deaths. A death that occurs within the first 6 weeks postpartum after giving birth is one of the timeframes we look at. And 44% of those deaths are pregnancy related. And a lot of those are related to things that we are talking about and why we are here today, which are things that if the women had recognized, or if the family member had recognized that something was going on, maybe somebody could have done something and prevented this woman from dying. And then the last group we look at is those 6 weeks to a year postpartum. And 33% of those were pregnancy related, 65% were not. But that doesn't mean that we don't want to pay attention to those. And in Delaware, we look at all of the deaths during pregnancy up to 1 year after the person gives birth. Next slide, please. This slide is very important too, because this highlights the overlap between our mental health conditions and our substance use disorder. And we only have identified one woman in Delaware who in this group from 2017 to 2021, who had a mental health condition, but did not have an associated substance use disorder. So it shows you that significant overlap between substance use disorder and mental health disorders. In addition, we have a good number of women who die of substance use disorders that we can't identify anybody who said that she had a mental health disorder. We do make a distinction. A lot of people think substance use disorder in and of itself is a mental health disorder, but we're also looking for evidence of other types of mental health disorders, like anxiety disorder, depression. We have women with bipolar disorder, etc. But there's such a link between substance use disorder and mental health conditions in Delaware. Next slide, please. And we mentioned preventability before. What could be done system-wide that might be able to help prevent these deaths? 89% of pregnancy-related deaths were identified as preventable. 81% of those that were not related to pregnancy were also identified to have had, there could have been something that somebody could have done. Could somebody have had Narcan available? Could somebody have called 911 when this woman didn't feel well? Was there something that could have been done? And then we try to identify ways that we can communicate what could have been prevented to the systems that might be able to do something about it so that these deaths might be prevented in the future. Next slide, please. And I do believe I'm turning it over to my colleague, Kim, here.
All righty. Welcome. Thank you so much for joining us. One of the things that we've learned from studying these cases and also studying the deaths of the infants, the fetal infant mortality review, is, as Lisa said, there's a very high percent of those that had some preventative ties to them, somewhere where we could have jumped in, something could have been changed in a system with a situation, with a provider, with the public, something in even in the housing, all kinds of things. So what we wanted to do is we made sure that as we're reviewing these cases, that we keep track of all that. We keep track of all the things that led to the death. We also have the femur cases, and you can see that some of the severe maternal morbidity cases, meaning ones that someone didn't die, but those we use those numbers. We base those on transfusion rates of at least 2 units of packed RBCs, and not all of those cases were just ones that needed blood, as far as they were also people that had to go to the ICU, things like that. But most of those women also had anemia. So maybe something that could have helped could have been potentially, information about prenatal vitamins. So when Lisa talks to the families and talks to the survivors and things like that, one of them is the lack of knowledge of the pregnancy complications. They just didn't know that maybe something they were experiencing could have led to a death of that person. The inability to communicate the urgency of that issue to the provider. So they just did not know what to say, or they were not being heard, meaning they said it 20 times, but no one really got the idea that, oh gosh, this is the one we need to be paying attention to. And the dismissiveness on the part of the providers and their staff. We all know we get 50,000 phone calls a day. How do you know that one of those calls is the one you need to be listening to? Next slide, please. So one of the things that we've done, when you look at the femur cases, you look at the babies that have died, and you also look at the severe maternal morbidity cases, those near misses, we realize that from a public health perspective and from everyone else, that there are, a lot of women who don't actually die. There's about 100 women who experience a near miss, so something that could have happened. So next slide. So what we decided is, when we all got together, we realized, we need something here. We need to be able to empower women. We need to be able to have something here, some kind of sign, some kind of poster, some kind of information that we can give to pregnant people. And we can give it to them, from the moment they get pregnant all the way up until a year after they deliver, because that's when they're vulnerable. We need to be able to say, these are the things that you need to call 911. These are the things that you need to call the office today. These are actually the items that could lead to one of those preventable, times of when we could jump in and potentially save a life. So what we did is we looked at what was available. A1 has something, and it's called the post-birth warning signs. Yes, it's wonderful, but it is exactly that, only post-birth. So it doesn't talk about things that could actually happen during a pregnancy. We also wanted something that, like the McDonald's colors, the kind of thing that promoted that sense of urgency, that red that means 911, that yellow, that means warning, warning, warning. We need you to take some action now. We wanted to focus, as we said, on the entire pregnancy. And we also wanted to make sure that we were addressing things like mental health, because that's something that not all the time it's not always addressed and realize, and it's not even understood as an urgent maternal warning sign, which yes, it is. And a lot of times they had high reading levels, which really doesn't help if you have an 8-year-old who's trying to figure out why mommy's not answering. So then we also looked at the council and safety in maternal health care, women's health care. They had multiple figures of multiple races, which we really liked. They had pictographs, but you couldn't really tell what things were, call 911 now and which types of things were to call the doctor's office. Next, please. So this is the one that's from A1. And as we said, we really liked the colors. We really liked the fact that there's even a little bit of a speech at the bottom, a little bit of like some prompting that says these are things that you need to say. But again, it's the post-birth warning sign. And we know that some of these things start while someone is pregnant. So next, please. And this is the one that's for the Alliance for the Innovation of Maternal Health, which is a big mouthful. So thankfully, they call it AIM instead. And a lot of you are familiar with the AIM bundles. The thing that we didn't necessarily like about this was the fact that it didn't have what things are 911, what things are call your doctor's office today. I mean, a 911 operator does not want to handle 51 phone calls of I'm having a large amount of vaginal bleeding today, because we don't know whether or not that's life-threatening or whether or not that's something that they could call the office. So we wanted to make sure that there was something that kind of, divided these into their severity. So next slide, please. We also wanted something, as we said, we wanted to lower the reading level by putting all of those medical terms that really didn't help people that were living with the pregnant person. So it didn't help the children or the husband or the wife or the next door neighbor, people that would also be coming to the scene that might not understand what those, very difficult words meant. We also wanted something that was easily translatable into multiple languages. I mean, maybe someone comes over and, they speak Turkish or something. So we wanted to make sure that the pictures could tell the story. And we wanted something that, would be usable, meaning that, it would be something that you could put on your refrigerator, something that the postpartum nurses could give the patients in their discharge information, that kind of stuff. But the big thing was also that script, because we wanted to make sure that we are using the magic words that say to whom it is that's answering that phone, wow, this lady really means something. This is something that needs to be taken care of today. This is something we need to send an ambulance to. This is actually the one that we need to intervene so that we don't lose this mom. Next slide, please. We also wanted to make sure that we are validating that with the providers and with the support people, so that we know that these pictures could also work for non-English speakers. And we wanted to make sure that we could have something that would follow the language and the pictures. Again, we hear stories of 8-year-olds calling 911 and saving lives. So we wanted to make sure that this was something that could literally be for everybody. And we also wanted a lot of input, a lot of stakeholders' voices. So if you are, as we continue this on, and you see something and you think, wow, we should, put this somewhere, or we should do this, please let us know. We are almost to the point where we want to print, but we really want to make sure that we've got a lot of input as far as what other people say. And we also want to empower the patient. So one of the, that's okay, go ahead to the next slide. We can just kind of go on. So as we said, we collaborated with AIM, which is, they're also with ACOG and with A1. And we asked them, may we use your pictures? May we, kind of divide this into what we're thinking? And then April really helped us realize that we needed actually a toolkit. It's not enough just to have one thing. We need to make sure that we're making, wall posters and wallet cards, and we're putting them in, OB offices and in triage and giving them to doulas. And, this is just a small sampling of where we wanted to put them. But community health workers, home visitors, WIC, state offices, other agencies, other nursing units, so postpartum and, 2M and antepartum and all that kind of stuff. So lots and lots of places. So again, if you have ideas, please let us know. We'll tell you how in just a minute. Next slide, please. So we have two surveys that we've put out on SurveyMonkey. One that gives the eye of the consumer, one that the eye of the patient, that kind of thing. There's another one that also tells us the eye of the provider. Have we listed all of the things that we want to be called about? I'm sure that you don't want to get 15,000 calls that people has a hangnail, so we didn't put that on there. But we did put a lot of things that we thought with it. These are the reasons that we can jump in. These are the reasons that we can save people's lives. So this SurveyMonkey will be available for probably the next week or so. We'd like to be able to, incorporate people's ideas into these forms so that we can then start going to print. So next slide, please. So this is actually what it looks like. We have a red side and we have a yellow side. The red side is the urgent, the call 911. This is the front side of the page. And you can see in there that it does give a little bit of history. So that little tiny bit of history tells people why we've created this form. This is not just decoration for your fridge. And we have then the call 911. And we tried to use pictures so that even children could understand this form. We also added the speech, and the speech to us is very important, because if you don't know the magic words, then you're just another person who's calling, screaming, crying into the phone, and you're not necessarily saying the things that are going to get a 911 operator, get their attention, or get your doctor's office attention. So that's why we put that in there. So we want to make sure that the person is actually saying what it is that they're experiencing and why this is an emergency. And we want to empower people to trust their own instincts. And then as far as on the yellow side, that has the things that you need to call your doctor about, today, and make sure that you're being heard, making sure that you're saying, I'm experiencing this sign. This is overwhelming tiredness. I can't get out of my chair. This is, my baby's not moving. I haven't felt it move today. I need to make sure that I'm doing things, very quickly. And if you can't reach that OB provider, then you need to go to the emergency room, because these are the things that, as Lisa said, if we intervene, if we jump in soon enough, perhaps we can prevent these. I mean, our goal is to, have Lisa sit on a beach and not have to look at all these cases. That would be great for our entire state. So next slide, please. So this is the wallet card. And, obviously this is something you can kind of fill out before and have with you, so that if you are found, someone could at least have an idea. Oh my gosh, this woman's been pregnant in the last year. We need to make sure that we're looking at her symptoms in a different light. You're actually putting when you had a baby, what kind of, the warning sign might be the part that you, are telling someone, saying, I'm having a really bad headache. I'm having all kinds of blurred vision. So if your preeclampsia ends up moving into eclampsia and you have a seizure, someone at least knows what's going on. So next slide, please. So as we said, big thing, we really want to hear what you have to say. We had so much great feedback from the last session. We definitely, we want this to be, in the community. We want it to be in the hospitals. We want it to be in every single bag that, pregnant people get, right when they get pregnant, right when they, when they are discharged from the hospital, when they're in triage, when they're seeing anybody, anybody that that has interface with a pregnant person, or a pregnant person that has recently delivered. We would like to have these in the hands of these people, so that they can then give them to the people that need them. Because again, the biggest thing we want to do is to be able to prevent those statistics. We want to be able to jump in, before we have the statistics. So that's the goal. So if anybody has any questions, any comments, anything that they want to say, anything they think they can help us with. Someone in the last session told us, make sure the 911 operators have it. Yes, big time. That's a fantastic idea. Yes, the corrections, I agree. That would be wonderful. DOC correction officers who have pregnant people in their population. Yeah. That's a good one. That's fantastic. So,
Yes, and I'm trying to put it in the chat right now. So 1 second, I'm just copying it.
Yes, I think that's share with churches. I think that's another
very good.
great idea. Great idea. Yes, this is something that we need to have literally everywhere. Anne has just put up the professional link at shelters. Yep, in shelter programs as well. Any place that we can find, where pregnant women are going to, eat, sleep, and breathe, wherever they're going to be. We want to be able to intersect the only way we can save someone's life is we jump in before it becomes, something that we can't.
Right. And I just shared the consumer one as well. So if you're not a
Mhm.
medical professional, go into that one that I just shared. We'll also make sure that this gets to DE Thrives so as well, but you can also reach out to us if you didn't get a chance to copy or go to the link below.
Right. And somebody also put up in here, share it with college students and nursing students and med students and any student. I mean, any college student, because we want to make sure that we're not forgetting something that, you all are going to be able to look at and say, oh my gosh, this is another huge sign that should be there. So yes, if you, yeah, Spanish version, you got it. We actually have a bunch of languages that we are trying to get it translated into. Haitian Creole is another. Um, but again, the pictures are something that we really want, because we want people to understand that, whatever they're experiencing is out of the norm, and they need to get attention quickly for whatever that problem is before it becomes life-threatening. Yes. Let's see. Train people. It's funny. I'm actually going to a Narcan event on Friday to go be Narcan trained. But yes, I agree. That would be something that we could have pop-up events and talk about this. And we're very thankful that the DHMIC invited us to speak today, so that we could get a large population of folks that have a passion in this area.
Well, we actually have 5 minutes to spare this time. That's great.
Speed talking.
I know. Last time we actually ran short, which is why we sped up our presentation this time.
Does anybody have any other questions or comments? You guys have been fantastic. So as breastfeeding peer counselors, yes. I agree with you.
That's good.
Again, we would like to have a poster that can be put on walls and backs of doors and all kinds of stuff. So, these pictures are going to be a lot bigger, so that people will actually be able to really see what's going on. And then the paper as well to go out with.
Ian, are you able to put up the flyer again so people can see it and see if they have questions on it?
Yes.
Just go back. There's research on
Yep.
why some women do not. Yes, there is actually some research on why women do not bond with their babies. And a lot of that is tied into mental health. And, that's why we do have on there that if you have thoughts of hurting yourself or harming your baby, if you look down, I'm not sure you can see my screen, but I'm circling kind of around where that is. It's, if you have feelings of hurting yourself or hurting your baby, that is a 911. That is something that we really need to make sure that someone is getting attention for. And as far as why somebody else might not want to bond with their babies, there's we want these people to feel empowered to be able to reach out to their healthcare provider, because perhaps they do have something that could be addressed, and folks could feel better. I mean, my golly, let's attack the mental health too here.
But the physical, a lot of women, because they physically do not feel well, cannot physically
Yes.
care for their baby.
Yes.
And that makes them feel like they're not a good mother.
I know.
And
Shout
so
out to Ingrid. Sorry.
it all links up together.
Yes, it does. It does. Ingrid, speaking of, I would like to connect you with Lisa. So that's somebody that I have been meaning to virtually introduce you to each other.
Hi, Ingrid. Email me.
Yes. So we want to hear from you. Let us know. Have we forgotten things? Have we added too much?
Yes.
Is it, not only are we looking at the informational content, but we also want to know about the way that it's presented. Is it too busy? Is it too colorful? Is it, all of those types of things. So
Yep.
all of that you can add would be fantastic.
Absolutely. Well, I think I want to thank all of you and thank Lisa and Kim for a fantastic presentation. Please take the survey. As Kim mentioned, it will be open for about a week, so we would definitely want your input. So thank you very much. Oh, Alexandria said she likes the colors. It draws your attention.
Great. That's
Yeah.
what we're looking for.
Yep. Awesome. All right. Well, thank you, everyone. I guess we go to our next session now. I don't even know what's next.
I think we get a break for a few minutes.
Do we get a break? Fantastic. Well, you
Yeah.
can go do your survey as you take your break. Fantastic. Oh, yes. And we are going to have the QR code right now. It doesn't go to anything because it's in development. But when we do these flyers for real, it will have a QR code. So good point. Very good point. All right. Thank you, everyone.
Thank you. Bye bye.